Welcome to Doc Talk, a weekly podcast featuring Monument Health physicians addressing medical topics. Tune into your health with Monument Health. Hello, everybody, and welcome to another edition of Doc Talk with Monument Health. My name is Mark Houston, and joining me today is Dr. Nicholas Czosnyka. Doctor, nice to have you on the show. I got your name right.
Czosnyka, yeah.
Okay. Where does that come from? Do you know? Have you ever looked into that?
It's Polish, yeah.
Of course.
That's my heritage, and it goes back, many generations since somebody actually lived in Poland. I don't speak Polish, but it sure is a confusing name, and I don't blame anybody for looking at it and saying, I don't know how to start.
How does that work?
Yeah.
Do you have a nickname that you go with at all?
Well, people call me Dr. Nick if that's easy.
There we go. Okay.
Works for me.
All right,
if
perfect.
it's easy for you, it works for me.
Now, you were in general surgery in Spearfish, South Dakota,
right.
with Monument Health.
Yep.
How did this journey begin for you, Doctor? I mean, where did the passion for this come from?
Yeah, that's a long story. So here goes.
I'm ready.
I actually went to college for finance. I had a degree in business, totally not really down a path of medicine. College can be that for some people, right? You're kind of figuring out what you're doing.
Yeah.
More of that and less flying as straight as an arrow. And that was my story. So I graduated from college, and though I had a degree in finance, I had a real strong interest in the outdoors. I actually was pretty obsessed with rock climbing and backpacking, and I ended up working for some companies that led teenagers who were battling different troubles of whether it was emotional issues or drug issues, things like that. And while they were out in the wilderness, and I was facilitating their safety by being there with them, they were also getting therapy with psychologists.
Sure.
Right? And so in that experience, here I am, a college graduate, a young adult. I'm watching these trained professionals really impact the lives of these kids. And I thought to myself, hey, I want to have some expert knowledge. I want to do something that really can impact somebody else's life in a positive way. And through some self-assessment, I was like, well, I don't think I'm going to make a very good psychologist. But I loved first aid. I loved, hands-on things. And so I just caught this bug where I was like, I think I want to be a doctor. And, then from there, pursued getting into medical school. Had to go back and take some classes because I didn't have all the science prerequisites and things like that. But ultimately, got into medical school. And then pretty soon after getting into medical school, you kind of hit this wall where you say, am I going to be a doctor that does things, procedures, or am I going to be a doctor that, is more cerebral, right? You're thinking, you're making diagnoses and applying these therapies, but you're not necessarily doing that through procedures. And I was really drawn to more the procedural side because I just loved the hands-on side of medicine. And that's how I ended up looking at general surgery. Right? General surgery is kind of this foundational part of the procedural side of medicine where we do a lot of different things throughout the whole body, whether that's what people typically think of, the abdomen,
right,
your intestines, the gallbladder, things like that. But then there's a whole other side of it, right? There's the idea of vascular surgery, breast surgery, endocrine surgery, things like your thyroid, trauma surgery, burn surgery. So there's all these different avenues, all rooted in the kind of the use of procedures to aid in people's care.
So general surgery can be all of those things you just explained.
Absolutely.
That's what.
Yep.
When people, I think, when they think general surgery, I guess that's
right.
The word to me, it seems, because you're still focused on certain things, but
absolutely.
Boy, it means that's a broad definition.
And so I think it's one of the unfortunate things about how we've named our profession is it implies something maybe minimizing versus kind of showing the scope of what general surgery is. And you're absolutely right. A lot of times people will take their general surgery foundation, which is a 5-year residency training, and then they may focus even more specifically and say, well, I'm gonna really do only, what we call hepatobiliary, right? I'm going to do liver and pancreas surgery, or I'm only going to do thyroid surgery. I'm only going to do breast surgery. And there are parts of the healthcare delivery system that that works well in, right? If you were to be in a major hospital in Chicago or New York or LA, things are very, very kind of sectioned off where this specialist does this, that specialist does that, and there's very little overlap.
I see. So you're from Illinois.
That's right.
Correct?
That's where I was born.
Kind of north of Chicago.
Yep.
Big city area, big city vibes. Now you're in Spearfish, South Dakota.
Yeah.
How did that happen?
Yeah, it's I love the path that I have followed. You know, when I left medical school, which was in Chicago, I was drawn to a residency in La Crosse, Wisconsin. My parents actually had kind of bought a small cabin up in Wisconsin, and this was near La Crosse. And believe it or not, my dad, who's not a physician, not in any way involved in healthcare, said, "Hey, there's this good surgery residency in La Crosse, Wisconsin. You should look at it." And it got me looking at it, and I thought, wow, this actually does what they were known for. It's called the Gunderson Health System. They're known for preparing surgeons to maybe practice in a little bit more broad context, what we call generically rural surgery. But what that really means is, okay, you're going to be maybe someone in a smaller town, and you are going to do some, breast surgery and some colonoscopies and
Sure.
some hernia repairs and some, minor skin cancer work. And so, as we all know, when you live in a rural environment, you just can't get up and run to, New York
Right.
tomorrow if you need that. So there's this small kind of application of broad medical care that works very well in a rural environment.
Well, and that has to be appealing to you because you say you wanted to be hands-on.
Right.
And so now you're getting to try a little bit of everything.
Absolutely.
Right? Yeah.
Well, and I think that there's that fine balance and kind of we're making a distinction that, okay, hey, we do a lot of different things and we do them well. We also need to know our limits, right? This is why when you come to a smaller town and, if you were to have a really advanced esophageal cancer or an advanced pancreatic cancer, unfortunately, it's just not going to be able to be taken care of in a small town. That's not an area of expertise that I have or my partners have. And the reality is, and what we've seen in research is, hey, you want somebody that does this all the time,
Absolutely.
taking care of you. You don't want the guy who's taking a crack at it once or twice a year, right? And so it's that balance of, okay, we're going to do a broad practice. We're going to do what we do well. We're going to know our limits and know when we need to kind of push things further up the ladder here in terms of the spectrum of care. But yeah, it's a wonderful opportunity to practice broadly, to see lots of different parts of your community, whether that's the different age brackets, right? You're dealing with middle-aged men who need a vasectomy. You're dealing with
and you're in a college town too,
Right.
so you've got that whole you run that whole gamut of people that retire to Spearfish, that go to college at Spearfish, that just live and work in Spearfish. So of all of these procedures that you do, it's weird to ask a doctor. Do you have a favorite surgery that you like to perform?
Yeah, I think it's a great question. I think my favorite surgery, and I mean this sincerely, is the surgery that helps somebody. Right?
Okay, that makes sense.
And I hear that. I'm not answering your question directly, but what I mean by that is we all want to make a positive difference. And so there's certain surgeries that I think are a little bit more of a guarantee, so to speak.
Sure, yeah.
Where like more times than not,
exactly,
this always helps,
and that's good to hear.
And
right,
right. And that's not just, we never want to do surgery that doesn't help, but the reality is sometimes when there's an emergent situation, nothing's going to get back to the way it was, right? It's never going to be perfect. But there are situations when, like, let's say, for example, an inguinal hernia, a groin hernia. A groin hernia is what we kind of say is bread and butter. Right? This is straightforward. This is a type of thing that, when you do this, 99 times out of 100, this person is going to be satisfied, their hernia is going to be gone, and their life is going to be better. And so that's the type of surgery that I love. I love surgeries where you're saying, okay, this is pretty much, we know the problem, we know the answer, we apply the solution, and you're better.
So that will lead perfectly into kind of what the focus of this is then, is varicose veins. Is kind of something that we're talking with you a little bit about today. Is that one of these types of procedures that can be, don't worry about it, we got you?
It really is. And so this is, when we talk about surgery, right? I think everyone hears surgery and they think, well, oh, I had a grandpa's his colon burst, right? Or they had a terrible cancer, right? Those are the tough situations. Those are the ones that don't necessarily equate to you coming in and going home the same day, right? Varicose veins, they're very common, right? We're talking probably 30-40% of the population, once you get to your middle age, has some symptoms of what we'll call generically venous reflux. Not just necessarily the veins you see that we all have seen, right? Bulging, dilated, tortuous veins.
Like some of those runners or bikers, sometimes they get those big bulging.
Right. That's kind of one end result of venous reflux. But venous reflux, venous incompetence, where the veins just aren't working as well as they once did, that can result in lots of symptoms, right? Whether that's swelling, leg heaviness, cramping, restless legs at night, kind of staining of the skin, what we call hemosiderin deposit, wounds, ulcers that won't heal. And so...
do those all fall under the varicose vein definition, kind of what you're describing?
They fall under venous insufficiency.
Okay,
they fall under basically your veins aren't working the way that they should. They're not helping blood get back to your heart the way ideally they would be.
Right.
And so blood's kind of pooling under higher pressure in your legs for longer periods of time instead of pumping out in a nice consistent rate.
Okay.
Yeah. But in that, when you have those problems, right, these aren't life-threatening problems for the very, very overwhelming majority of people, but they're extremely impactful in people's lives, right? People that stand at work for 10, 12 hours at a time.
Yeah.
It makes life hard to deal with these symptoms. And so the fact that there is potentially an answer or a solution to resolve those problems for people is great, and that's why I like it.
Okay. Now, I understand that with varicose veins, well, really quickly, specifically, what is a varicose vein?
Yeah. So a varicose vein is a dilated or stretched out vein that has become prominent, right? And so if you think about your veins like a tube, right, these veins have valves, little check valves in them. And so blood can pump up out of your leg up against gravity. And then in a nice healthy vein, between the beating of your heart, when blood isn't moving, it won't fall back against gravity, right? And your vein works to kind of stepwise advance the blood up towards the heart. But if that vein becomes stretched or dilated, well, now all of a sudden that blood moves in a more turbulent way. It goes up, it goes down, it doesn't just march in one direction. And the longer that happens, the more the vein can stretch. If it stretches enough, well, then you can see it. And then that's what we're seeing is the varicosity, is that dilated protuberant vein.
So does every vein in your body have that? Is it all work? Do they all work the same way in essence?
Essentially they're all, if you think about it kind of like the roots of a tree, right? The roots of a tree, they're collecting all this water and it's bringing up to the central trunk. And our body has these kind of trunkal areas where all the veins meet. So coming up out of your leg, all the veins either come out of what we call a superficial system. Those are the ones you might be able to see underneath your skin. And there's a deep system that run kind of more down by your bone and underneath your muscle. But one way or another, all that blood is coming up right into the groin crease there and into what we call the femoral vein. And that's how the blood gets out of your leg. And so it's a system that's working together to find a path for blood to get out of tissues. And that's one of the things that allows us to do these treatments. I think we'll talk more about that. But by having redundancy or different pathways blood can take, it allows us to eliminate a pathway that may be causing you symptoms without causing any detriment to you.
Boy, our bodies are weird and amazing all at the same time.
Sure.
So I think heredity plays a lot with varicose veins, doesn't it?
Yeah. There's no varicose vein gene, so to speak, but there's no question that, people that would say, oh, my grandma had terrible veins, my mom had terrible veins, and I have terrible veins, because it is a question of your connective tissues, right? Your veins are made up of tissue, and some people's tissues are robust and they never have have them kind of stretch out and become incompetent. Other people's, for whatever reason, they're 25 years old and they've got huge veins. And then there's also parts of life that make you more prone to it, right? Pregnancy can kind of be a precipitating factor. People's what generally called lifestyle, right? If you stand on a concrete floor for 12 hours at a factory every day for 30 years, that can put a lot of strain on your venous system. So it's that combination of hereditary kind of predisposition, but also lifestyle factors.
So a lot of people that have varicose veins, and people, if you're familiar with them, you know that sometimes they look unsightly.
Yep.
Sometimes.
Yep.
But is there ever a medical reason to treat them?
Absolutely.
Is there?
And actually, that's really one of the most important differentiations when it comes to venous insufficiency and varicose vein treatments, because as a medical provider, we're always at this interface between, what can we do to help you, and what would, let's say, your insurance company be willing to pay for.
Go. Right.
And so insurance companies don't love to pay for cosmetic things if the only thing that's bothering you is, I don't like the way this looks. Right. And so sure, well, we all know that. We all have varicose veins that aren't what we want in terms of appearance. But in terms of medical symptoms, you can have swelling, you can have bleeding, you can have your veins become clotted and inflamed because of the blood staying stagnant and irritating the veins. Like I said, ulcers can develop, and just pain, right? Just symptoms of discomfort that don't resolve despite your best non-invasive treatment options. So people can often have resolution of symptoms if they just wear compression stockings, right? Mm-hmm. But compression stockings, which just kind of augment the veins, instead of that vein being dilated and those valves not working, now it kind of compresses them, and now maybe the valves work a little bit better, so you don't have the same symptoms, but you have to wear them, right? And maybe wearing them causes you other symptoms, like it wears on your skin or it cuts into you.
They're not comfortable in a lot of instances, right?
Yeah, they're not comfortable. So it's one of those fine balances between, what can we do that's non-invasive, that you can tolerate and manage for a long period? But if those non-invasive therapies aren't helping, well, then yes, we have good reason to recommend more advanced therapy.
Can they be dangerous?
Varicose veins?
Yes.
So very, very, very rarely can they be life-threateningly dangerous. You could end up in pain. You can end up with a wound infection. In the very rarest of cases, sure, you could have a thrombosis or a DVT. Generally, in your superficial veins, if you were to have a clot in the superficial veins right underneath your skin, that isn't going to necessarily become a deeper problem. But you can have a DVT, but those are rare. Those are very rare things.
So when you go in, how does the procedures work then to fix that? So when they come into you and they're ready to go, what do you do?
Yeah, so there's kind of three main therapies that would be applied. I'll start by saying it's one of the things that's frustrating for patients is it's not often come in to see me, come back the next day to get fixed. There is quite a bit of a process involved with diagnosing, really clarifying where in your venous system reflux exists, understanding if maybe you could improve with non-invasive therapies, and if you could, maybe that you wouldn't qualify for a surgical option. So let's assume we've kind of gotten past that threshold, which unfortunately can be measured in months sometimes before we can really get to a point where all the ducks are in a row and we're saying, here, we're doing this. But there's, at the most basic level, there's something called sclerotherapy, where we're injecting a sclerosant, or basically a chemical that irritates the vein enough to where it basically clots itself and stops working, right? If you think about veins, is if you can stop the blood from flowing through the veins, then the vein isn't there, right? If you think about it like that. I
suppose, yeah.
And so the blood will find another way. And so sclerotherapy is an injection of a sclerosant, or this detergent that is usually foamed and placed into very small veins, causes those veins to basically scar closed, and then blood can't flow through them. So in a small vein that's right underneath the skin, what we might call a spider vein or a telangiectasia, those might then not be visible anymore, right? And so if that area is not visible, isn't tender anymore, isn't bleeding anymore, then that's resolved. So that's the simplest. And then in some cases, people maybe have already had kind of more of a systemic treatment that I'll talk about next, and maybe they don't have the options for a kind of a more central systemic treatment, and we may just apply what we'd call a phlebectomy and say, okay, well, we're just gonna cut out this one offending vein, and it's a small surgery where you're just talking about a small incision just on the skin, just to basically get down to the vein and pull up that small portion that's causing trouble. But after those two, and the therapy that is more of a systemic treatment, is this idea of ablation, or basically closing the vein. And so what I do is what's called radiofrequency ablation. There's different ways to get veins to close or not have blood flow through them. I do RFA, or radiofrequency ablation. There's laser ablation. There's basically glue that can be used to fill the veins. I don't perform that myself,
Okay.
but these are all accomplishing the same goal, and that is deleting this pathway for blood to take, right?
Right.
So if you look back 20, 30 years ago, you probably had somebody that said, oh, I had my veins stripped.
Yeah.
Right? They basically had their an entire portion of their superficial venous system, let's say, for example, the greater saphenous vein, just pulled out, right? And so this is where you hear stories of like, oh, this really hurt. I bruised terribly. Worst surgery I've ever had, right? Very, very few people, if anybody, do that anymore.
Okay.
Right? Because the alternatives, which accomplish the same clinical endpoint, are so much better tolerated.
Right, exactly.
Right, and so that RFA, what it's doing is we're taking, okay, we know the offending vein.
Yep.
This vein is too big. There's reflux. The blood's not flowing in the right direction. We think it's the source of all of the other cascades that kind of come from that, the dilated varicosities, the swelling, all these things. So we're going to place this catheter into the vein under ultrasound guidance. We're going to kind of bathe the vein in some cooling and anesthetic or kind of pain-numbing solution. And then we're going to basically heat that little catheter up, the little wire, and it's going to burn the vein, irritate the vein enough to where then, when given some compression and time, the vein scar's closed. It doesn't allow for blood to pass through it anymore. And by doing that, that system, that pathway is deleted, and now blood has to go a different way. And so preferentially avoiding the areas that are causing you symptoms.
Right. Oh, that's amazing. I get so fascinated by the technology that can be used in so much of this stuff anymore. So how can people, is it preventative? Can you prevent these generally? I mean, if you're predisposed, you're predisposed.
Yep.
Right.
So that's one of the kind of, I'd say, threshold issues with being eligible for this. You really need to have the problem. I wish I could say that there's a way that these therapies I just described, they're applied when you have the problem.
Got it.
So the prevention would come from, okay, well, I'm going to wear compression stockings, let's call it prophylactically, right? I'm going to do this in advance, right? My mom had these. I'm working a job where I'm on my feet all the time, so I'm gonna wear compression stockings even though I don't have.
And that can work.
Yeah. Yeah, it certainly can slow the progression. Absolutely.
Oh, that's excellent.
Yep.
Well, this has been a great conversation, Doctor. I love finding out these things that are so common that people have, but they have all these questions about, and they, without going to a doctor, they don't get the answers.
Right.
But now you've answered so many of them right now.
Good.
So I really appreciate it, and I do hope. I think down the road here we're going to get to talk with you again.
Yeah.
So I'm super excited for that, and I'm glad to have you on the show. One last quick question: are you a Bears fan, Doctor?
Oh man, you brought up football.
I had to because of where you're from.
So I spent, my early years in Chicago, my training years in Wisconsin.
I know that's the.
So my mom actually grew up a Green Bay fan.
Okay.
She's the stockholder on the back of the basement wall. She's got her single stock.
That's great.
Issued. So I really don't follow either of them closely. But if I were pressed, I'd probably say I'd rather watch Green Bay win than the Bears.
See, now I'm a Vikings fan, and you just hurt me both ways. It doesn't matter. Dr. Nicholas Czosnyka from Spearfish, general surgeon up there with Monument Health. Thank you so much for talking with me.
Thank you.